is Liver Analgesia, the Indian scenario. First of all, I bring greetings from the land of one-horn rhino, the enchanting Bihu, and the land of tea gardens, the land of Assam. And I invite you all for any kind of future conferences, if it's possible, near future. So as we all know, India is a vast country, starting from Kashmir to Kanyakumari, from Assam to Gujarat, stretching a 3,200 kilometer across. So there is a differences in the cultural belief, the socio-economic status, the doctor population ratio, the urban and rural based, everything is varied here. The healthcare system is also varied, starting from the government to the private sector to the corporate setups. The practice of labor analgesia is essential part of the standard obstetric care, but at the same time, it is surrounded by various myths and controversies. So when we see the various guidelines and programs which has been set up in the labor pain management in developed countries, like in UK, that 1/3 of the participants choose for the epidural analgesia. In UK, and studied, like about 73.1% persons received the neuraxial labor analgesia. But India, we don't have one data to see that the practice of labor analgesia is this much, but they had done some studies in various centers in came out roughly to be 11%. So what is the cause or the etiology for this cultural? It is due to the failure factors we are not able to implement. It is mainly due to the lack of infrastructure. I'm not saying in terms of the facilities, but also in terms of the staff. The population burden is a huge problem because there's disproportionate of the doctor to the patient relationship. The ratios is varied. The lack of knowledge and awareness, both in terms of the patients and healthcare providers. The healthcare providers are so very burdened that to acquire knowledge, to go from one place to another also, it becomes a huge problem. The budgetary constraint in the government setup is well known, whereas the insurance-driven private hospitals are better off. The cultural beliefs, if we say in Assam or in the state of Gujarat or Rajasthan or the northern part of India, the total cultural values and beliefs are different. In some cultures, it has been taught that it is mandatory to bear the labor pain for a girl child as soon as they become that bearable age. But again, and some in metro cities, we bring and brought up our both boys and girls in an equal manner, and we don't feel like the tolerance for the pain is not there. So education, the rural women are again, even they are educationally poor, their tolerance power to the pain is much more. So in India, the practice of labor analgesia, they have done a study through the SurveyMonkey website, and they had given like 11,000 anesthesiologists a questionnaire, and where the 1,300 has responded to the survey. And they have found that this had came into a journal like practice of labor analgesia among anesthesiologists is a cross-sectional study, where they have found out a data that the government hospitals and the government medical college has the lowest in the graph diagram, as you can see, and the private medical colleges of 21%, the corporate hospital comes to like 31%, and the private nursing homes and the hospitals comes to like 32%. So this variations is always there. Again, the labor analgesia practice is most common among the anesthesiologists in India, and they mainly go up for the regional anesthesia. Again, the anesthesiologist and the obstetricians comes the second, and the obstetrician alone comes the third. Again, after the regional, the systemic analgesia is common, and the least are the non-pharmacological methods which they use. Then when we had did the study, that they have found that the obstetrician in India, the IV route, the tramadol being the most common drug, next comes to fentanyl, then pentachusine and meperidine. On inhalation, they had found that Antonox is the most common, followed by the nitrous oxide enoxazoline and the sevoflux. When they had found that the regional anesthesia techniques practiced by anesthesiologists is that the epidural analgesia with the intermittent bolus dose is the maximum which they use, is 44%, and the continuous epidural infusion using the syringe pump is 38%. The combined spinal epidural and Parkinson's controlled epidural analgesia is less, whereas the single shot spinal epidural is the least common, followed by the pudendal and the paracervical blocks. And in the studies, they had found that the drugs used in regional anesthesia is the most common for analgesia they had used is the bupivacaine, which ranks the first, the ropivacaine being the second, and levobupivacaine and the lignocaine the last. And it comes from the bupivacaine of 64%, and the ropivacaine and the levobupivacaine are listed. The adjuvants which they had used, the fentanyl being the most common among them of 83%, which is a lipophilic agent, and being it is a shorter duration, it's safe for both mother and fetus, and the clonidine being the second. So to conclude, the route map is a wavering pattern. We have a varied amongst the government hospitals, government medical colleges, private hospitals, some corporate hospitals in India, starting from 30%, may exceed to 50 to 60%, as like Fernandez hospitals are doing, the private setups of 32%. But the goal is yet to achieve. So at the end of this, I feel like we will be all able to manage the labor analgesia in our own setups to some extent. Thank you all for your hearing.
Good afternoon, everyone. It's absolutely my great pleasure to be with you. And I have to thank Dr. Sunil Pandya, Dr. Ketan, Parikh, and Dr. Ravindra to have made this possible for me to share my experience with you. It's been absolutely wonderful that they have put in enormous efforts to make this conference a reality. I used to work in Qatar, Singapore, and England. And I came across quite a few well-fed people. I'm sure all of you have. I'm no different. Say around 25 years ago or 20 years ago, I used to lose my sleep if I knew that there is a well-fed woman on my list next day. Because I have come across, and so have you, many mini elephants, mini whales who you have to put epidural the next day, and you do have some kind of anxiety. Well, I found a best friend in anesthetics, in regional anesthesia, and that's called ultrasound machine. It used to lie in radiology department when I was a trainee in Sassoon, which is in Pune. And I never touched it when I was doing MD in 1992, but in the last 20 years or so, of course, it's become a part and parcel of anesthetic training, and it's wonderful. Believe me, if you are well versed with finding the ultrasound guided epidural space, then you can be rest assured that you should be okay to put the epidural in even a bad spine. My talk is going to be very practical, and I'm going to be talking very basics and then hands-on. So first and foremost, when we say ultrasound, what does it mean? Sound is a sound. We listen, we hear, we communicate. So one of the most important functions of sound is it can help to see what is hidden. So it's not only the eyes, it's actually our ears, or actually the ultrasound, which is doing what the ears should do. For example, the bat, when it goes for hunting at night, it finds a strawberry. He wants to eat the strawberry. So what it does, it emits the sound waves. It hits the strawberry, they bounce back. The bat exactly knows how long it took, and he eats the strawberry. And that's exactly what we do when we use the ultrasound. We emit the sound waves, ultrasound waves, we catch them, we find the figure, we find the depth. We know exactly how long it took, and we know exactly where we need to go. So sound is nothing but whatever we can hear or human ear can hear. So above the frequency, audible frequency of human ear, which is around 20 to 20,000 hertz, above that, what we call is ultrasound, and is exactly the audible frequency of the bat. And below that, what we call is an infrasound, which is the audible frequency for animals like elephant. So how do we generate the ultrasound? Well, there is a special material called as piezoelectric crystal, and that lies in the ultrasound probe of every ultrasound probe. What happens is that when we apply the voltage to the PSC, it expands and then it contracts, and it emits the sound waves, which are ultrasound waves. And then we get the images by computing. Now, few important things to remember before we start using ultrasound. The basics, like what are important structures you need to understand, what are the things which you need to apply so that you are well versed with ultrasound. So the biggest enemy of ultrasound is the bone and air. Air nothing passes through the bone and hardly anything passes through the air. So we need to take even the small air bubbles between the probe and the patient's skin. Otherwise, the skin, they will not just pass through. So for example, here, there is an air bubble, there is an ultrasound probe. We need to have, nothing is passing through that. So we need to have something here for the ultrasound to pass through. And what we do, we use a liquid medium like jelly. So a jelly will keep away any air bubbles and allow the ultrasound to pass very easily. That's the jelly. That's the ultrasound machine. Everything is passing through. So that is what I mean. Now, when we have passed the ultrasound waves inside, what happens? Some waves will return back. Some waves will not, because some waves will get absorbed. The energy will get absorbed in the tissues. So everything doesn't come back. So this energy is wasted, and more deeper our tissues are, deeper energy is wasted. And that is what we call as attenuation. And this is one of the reasons why we find it more difficult to see the deeper structures. This is an ultrasound probe. I've not shown you the jelly, but please understand that there's a jelly here, and then the waves are passing through. So just see initially the thickness of the bands, and then it slowly deepens down and becomes smaller and smaller. It becomes a bit difficult to identify the deeper structures, but we'll make it happen. Now, other important thing for you to know, which is right from the 8th standard physics, we learned what is called as resistance, impedance. Acoustic impedance means impedance of the sound by various tissues. Depending upon the density of the tissue and the speed of the ultrasound in tissue, the acoustic impedance is going to differ. What we need to know is what frequency, what wavelength ultrasound is going to generate, because there is a direct formula for frequency and wavelength. If you want to have if you want to see the deeper structures, we need to have a wavelength which is going to penetrate into the deeper structures, which means we need to have a lesser frequency, because frequency is number of high or low pressure cycles per second. For example, we have 2 to 20 megahertz frequency probes. We hardly use 20 megahertz. We use normally 2 to 15 megahertz. So the lower the frequency, higher is the wavelength. So PEC creates high and low pressure waves at practically megahertz per second. And that's the reason we say 2 to 20 megahertz. The distance between two identical points on a high pressure or low pressure wave is called as the wavelength. So the higher the distance, higher the wavelength, smaller distance, smaller the wavelength. And as I said, is a direct relation. Wavelength is inversely proportional to frequency. So higher the wavelength, lesser the frequency. Higher the frequency, lesser the wavelength. Now, another important thing to note is resolution. Resolution means ability to see two things as two things. And resolution becomes poorer and poorer, image becomes blurred and blurred as we start going deeper and deeper. So we have to have a higher resolution. So we have to find somewhere some match, somewhere where we can get a better resolution, but at the same time we can go into the deeper tissues, get a better depth. Epidural space is deeper structure. For example, intrajugular vein is a superficial structure. So you require different kinds of probes to identify these ones, because you require for superficial structure, you require a higher frequency, so lesser wavelength. For epidural space, which is a deeper structure, you require lesser frequency and higher wavelength. So let us link everything together. Low frequency, better depth, longer depth, lesser resolution. At the same time, bone and fat are hyperechoic. Air will not allow any ultrasound to pass through. Water is better. Water is a better medium for ultrasound to pass through. Different tissues have different compositions, and every medium will have different acoustic impedance. And we have to remember that anyone who wants to do the ultrasound guided epidural or even the block, you must do ultrasound yourself if you are the operator, because you need to have the probe held exactly perpendicular to the structure you are trying to identify, because otherwise you'll be completely out of the beam and you don't know what you're going through. So the different types of probes are A, which is a 2 megahertz curvilinear probe, which is the one we use almost always for finding the ultrasound, finding the epidural space depth. Sometimes we have used this in a thin patient's B. Actually, the images you get with B are better than the images you get with the A, but you have to understand that the frequency of this B is a bit higher than the frequency of A. 2 megahertz, this is around 5 to 10 megahertz. So the penetration is lesser, so the resolution is lesser, a bit difficult to identify the epidural space. Coming back to basic anatomy and describing the planes. So midline plane, paramedian plane, oblique plane, transverse plane. That's exactly what is shown here. Transverse plane, sagittal plane, coronal plane. So that's the way we are going to hold the probes. Please remember this: paramedian, oblique paramedian, and transverse. We'll come to that very soon. So if you put the probe as transverse over the sacral hiatus to sacral coronal, what you will see is nothing but the sacral hiatus. So this is like a frog's ears, and these are the frog eyes, and that's called as frog eye sign for sacral hiatus. Yeah, important to a structure to note for the people who do chronic pain, because for the caudal epidural we try to find sacral hiatus. Now, as I said, bone is enemy of ultrasound. So see, this is the spine. This is the first landmark when we are using blind technique. I mean, that's our routine technique. So if you palpate the spine and probe and put the probe exactly on the spine, nothing is going to pass through. No ultrasound waves will pass through. So you'll see everything black, nothing there, because you're basically putting the ultrasound over a bone. So nothing will pass through. But there's a whitish line here. Can you know what this is? Can you tell me what this is? Well, these are the laminae, because this is the probe or the spine, and what is next to the spine are the laminae. So what you're seeing are the laminae. Yeah. Next one, after you have found that this is the spinous process, you need to go between the spinous process, which is exactly what you do. When you put the ultrasound between the two spinous processes, you will see nothing but ligament, the interspinous ligament shadow, and the only white structure which is of paramount importance to us, most important structure for us, is posterior complex consisting of dura and ligamentum flavum. This is what we want to know. When you go paramedian, in difficult patients, we do go for paramedian approach. So we see the laminae, and we get the paramedian beam. Beam goes through paramedian plane, and you again can find the depth between the center of the probe and the ligamentum flavum. These are laminae. These, like seesaw, are laminae. Seesaw are laminae. So this is the ligamentum flavum, and this is where the probe would have been. So these are the laminae, and you are directing it obliquely. So again, bridging everything together, paramedian, oblique, and transverse. That's what we do. When we are putting the probe transverse, we already identified the space now. We identified the distance from the space, from the skin of the space, and then we are going to mark the point of insertion. Remember, this point is the point which was the midpoint of our probe, which is where our eyes were. I mean to say the eyes of the ultrasound probe were, and that's where that's where the beam was traveling through. So this is the point of insertion. Very, very important for you to remember. How we mark? Identify the midpoint of the probe, draw a line. Identify the midpoint of the probe, draw a line. Similarly on the other side, and then you get the cross, and this is the point of insertion. I'm going to leave you with a video. As I said, like normally what we do is we demonstrate this in a live patient, and every one of you would have got the opportunity to actually see this and use this and ask us this. So this is my own video, which is quite an old video. It's 2014.
Okay, when you do the lumbar sonoanatomy, you start from identifying the structures from down. So the first structure you find is a sacrum, which will be like a continuous. Show the morphology first, and then we can get a sono picture where you are now.
So please remember that there is this was an interactive session where the audience could ask you the questions, and that's the reason you are going to hear questions and me answering them.
Anatomically, okay, you are at the bottom of the, your patient is sitting.
So that's the probe I'm mentioning. It's a curvilinear probe, 2 megahertz probe. Patient is in sitting position. We are going to go paramedian now.
Sitting position just now because we are using the same patient. We are using the same probe, and the same patient is going to have cervical epidural also. So she's in sitting position. Okay. This is the obviously the bottom of her. Okay. And so I'm going to start paraspinally, means away from the midline, and I'm going to place the probe like paramedian and sagittal plane. Okay. So this is where I place on the capillate side. So this is the cranial cephalad, cranial side, okay, and cephalad side. The patient, the probe is in the paramedian.
So this is the cranial side, and there's the cephalad side.
Parasagittal. And then I placed it on the bottom, at the lowermost part of lumbar spine, I would say.
So see, what you are seeing is a continuous wide structure, and that has to be nothing but sacrum.
You see the sacrum, that's the first anatomical structure you see, and you want to see because then that you can, you know where is L5, where is L4, where is L3. So there's a continuous structure. The right side is towards sacrum. Right side, the pointer is at the sacrum. Okay. Yeah, because it will be seen as a continuous line now. I'm moving my probe up slowly. Yeah. So the first structure I see where you can see the black complete shadowing there. Yes. Where the pointer is now is L5 because that's the first lumbar vertebra, isn't it? Yes. From down. I go up, I see L4. That is now coming in the picture. I'm getting in the center of the picture, and that is L4. Yes. Which will be complete hypoechoic. And what is
because you are now in the midline, so you are literally encountering the
articular surfaces, if not the laminae of the lumbar spine, because you are paraspinal, you are parasagittal. Okay. Yeah, you're not in the midline, you're away from midline. Yes. So you will see how we do the translaminar approach or paramedian approach, isn't it? Yes. So that's what you're seeing now. Now I'm going to rotate the probe transversely. You can see on the screen there, I'm moving it transversely. See how the picture changes there. Can you see? It's basically a complete shadow.
So I have put the probe now transverse here, and now you can see the picture has changed completely. And now there's a full shadow, which means I'm at the spine because nothing is passing through.
Yes. Yeah, because complete black shadowing, isn't it? Okay. Because basically I'm pointing it towards the tip of the lumbar spine. So there's no acoustic medium going through. It's a bone. Yeah. So now I'm moving it slowly upwards because now I can see between.
So now I have moved the probe slightly upwards, and now I can see between the spines and see this beautiful structure. It looks like a bat's wing. And this is our main structure, the white structure we are talking about.
In the spine. Yes. So that is intraspinous. Yes. And what you're seeing, the blackish line from the yellow pointer downwards, yes, from yellow pointer downwards is the interspinous ligament. And then what you're seeing is the posterior complex. Yes. And the pointer now is pointing towards the posterior complex, which consists of ligamentum flavum and dura. Please freeze the picture. So what you're seeing is now ligamentum flavum and dura.
So now what we do is, after you have frozen the picture, we want to measure the depth from the midpoint to the white line, the midpoint of this white line. So this is the posterior complex, which consists of ligamentum flavum and dura, and then you will measure the depth. And that depth will be practically the depth of epidural space, provided you are not pressing too much on the skin.
Yes. And now you can see on the picture something called as a bat swing appearance. I'm just showing it through the pointer. Please follow it. Can you see that like a bat swing? Yes. So that is something you'll see when you're interspinous. And now let us measure the depth of the epidural space. So from the yellow triangle in the middle of the screen towards the green arrow, which is the first hyperechoic line, is the ligamentum flavum and dura complex, this posterior complex. And in her, she's a very thin patient. You're finding it at 3.44 centimeters, which is probably expected in her body habitus. Okay.
So you will find the epidural space somewhere at that depth.
That's correct. Now, 2 points to remember that this is an approximate depth because you are after all pressing the probe against the skin.
Tissue compression will come into play.
Exactly. So you may be quite happy to go up to 3 centimeter, but afterwards you have to be a bit cautious, and then with the loss of resistance syringe, you will find it somewhere between 3.4 to 3.5. So just
you mean to say it's a very good guide to judge the depth of the space.
It's an excellent guide to get the depth of the space. Yeah.
Shall we have the other picture?
Sandeep. Yes. Swarup. This is Dr. Swarup.
Dr. Swarup is asking some questions.
Sandeep, can I ask a question? Yes, please. Yeah. Do you think ultrasound actually underestimate or overestimate the skin depth? It does not tell you the exact depth. It depends on how tissue compression you have got. So it will tell you approximately at 3.44 in her, you will see the you should be getting the ligamentum flavum. Once again, I've got the picture here. It's in the center of the spine. Also, everything depends on the position of the patient. Because the patient moves or your ultrasound probe moves, then obviously the depth will be different, isn't it? What's your clinical experience? What do you think? It's correlated with the ultrasound depth, or it's varying with the how? It correlates very well to the ultrasound guided estimated depth. Yeah, probably a couple of millimeters here and there. Yeah, means from say if we found it at 3.44, I probably will find it between 3.4 to 3.5. Yeah, and what's your experience about the thoracic region? Does it actually helps in the thoracic? Lower thoracic certainly yes. Upper thoracic probably not as effective because the ultrasound image is not that great.
Yeah. I have a question. Here you are judging the depth as a perpendicular to the skin.
Yes.
But when you are doing an epidural puncture, you are often oblique. So that also you must be taking into account, isn't it?
Well, you're obviously estimating the depth in the beam of the ultrasound, which is in this case was in the midline.
Yes.
And when you go paramedian, then you can see the ligamentum flavum. You can even measure the depth of ligamentum flavum, but then you will be out of the plane. So you may not be able to get exactly the same depth because you are completely out of plane. If you go in the plane, then you should be getting the epidural space exactly at the same depth you found it.
That's right. So obliquity, the compression, and the plane, which is paramedian, are all of them change the depth to some extent.
No, we got that. My point is that if you have got a clear depth with the midline view, for example, here, then I will obviously go in the midline. I will not go paramedian. If I'm going paramedian, then can you just freeze this picture, please? And then please, if you could take the pointer at ligamentum flavum, which is that, yeah, that's the ligamentum flavum. Okay. So you still can measure the depth, okay, but when you're going paramedian, you really are going completely out of plane because you're going to take the probe out and then you don't know which direction you're going. Okay.
Thank you, Sandeep, for that excellent demonstration on the sonoanatomy of the epidural space.
So I would like to thank all of you to have given me this opportunity to share my experience. Any questions are welcomed, and I'll do my best to answer your whatever doubts you have. Thank you ever so much.
Good afternoon, everyone. This is a part of the labor analgesia workshop. A few talks in the beginning. When I was given the responsibility of this talk, I tried to look into the dictionary and see what is the meaning of myth. In the dictionary, it says that the myth is a widely held belief which is false or unverified, totally unverified. A controversy is an issue on which there is no consensus. At least the house is totally properly divided. So with this background, I will try and speak on some of the myths and controversies in labor analgesia. So before going into the myths and controversies, let us see some of the issues which are totally resolved, which are no longer a controversy. Number one is, does labor pain exist? Yes, everybody agrees now that the labor pain definitely exists. Number two, is the childbirth is sacred, which everybody agrees, and should not be meddled with, is something, daisy, because the mother and child bondage is linked to it. This part is again solved, because you see, if you see, you take the a mother who has delivered a baby by cesarean section, not getting labor pains at all, and she doesn't, just because she hasn't experienced the labor pain, she doesn't throw the baby out of the window. So the mother and child bondage is something different, and it is not linked to the labor pains at all. The third one is labor pain is inseparable from uterine contractions. That is also resolved. One is humoral mediated, the other is dural mediated, and they can be easily separated, and one can be blocked by without affecting the other. Whether painless delivery can be called normal delivery? Yes. Normal delivery is defined as the route of delivery only. Any vaginal route of delivery, whatever you do, is a normal delivery. So this is again a solved issue. Now let's go to the controversial issues. Non-pharmacological controversy number 1 is non-pharmacological methods of labor analgesia provide effective pain relief. This is what is a statement. Now, the two techniques, the psychoprophylaxis and the childbirth preparation, that is during the antenatal time itself, preparing the mother to bear the pain, preparing the mother to understand what labor and delivery is, and then going on telling her, preparing her psychologically, allows her, makes her tolerate the labor pains better. Of course, this helps to a very great extent, number 1. Number 2, it enhances the effect of any other route of, any other method of analgesia to a very great extent. Hypnosis, acupuncture, and TENS have some evidence, but not completely reproducible. All other methods have, in fact, almost near zero evidence. They are not reproducible. One study says that it's very effective, and if you try to emulate it elsewhere, it doesn't work at all. But all of them, most of them are harmless and may give some amount of maternal satisfaction, so you can use them without much problem. The second issue is Entonox is not safe and only a little better than placebo. This is the second issue. But there are 3 controversies in the Entonox usage. Number 1 is it causes nausea and vomiting. That is not great, because Entonox causes anywhere between 5 to 26% nausea, vomiting, and normal labor itself causes 6 to 20%. What is great? What is the great fun in it? So it does not. Number 2, desaturation. Of course, theoretically, diffusion hypoxia should cause, hypothetically, should cause diffusion hypoxia, desaturation. But the amount of nitrous oxide given, 50% only, and the duration to which it is given does not cause that bad desaturation. So it is reasonably safe from that point of view. But when it comes to the question of efficacy, analgesia is, any analgesia for that matter, is only 50%. No analgesia in 50%, and complete analgesia is only 10%. So the efficacy wise, Entonox is not a great thing at all. The third controversy is systemic opioids, systemic I mean, provide effective pain relief and are safe. See, opioids only increase the pain tolerance. Efficacy is just acceptable. That is systemic opioids I'm talking about. The difference between the systemic opioids and the neuraxial opioids, from the point of view of concentration, from the point of view of the amount of drug being used, is great. Only about 3 to 10% of the systemic dosage is used neuraxially. So the problems are less, the efficacy is good. The effects on the fetus, neonatal respiratory depression, like with the narcotics like morphine and tramadol, is not effective. It doesn't allow you to use them in good concentrations, which gives a good analgesia. This is systemic opioids. Remifentanil, of course, the fetal safety wise is fairly good, but maternal safety itself is questionable. So systemic opioids are not a good choice. Coming to neuraxial labor analgesia, The one most important question is when to place an epidural. Epidurals should not be placed in labor till the mother is at least 4 centimeters dilated. This is a myth. Actually, what has happened is somewhere in 1960s and 70s, when they were using the higher concentration local anesthetics for labor analgesia, they were thinking that it's going to be fairly effective, and it delays the first stage of labor. That is what the situation was. But later on, the studies have proved that it doesn't affect the progress of labor to that extent. So now, after the Cochrane review in 2000, and subsequently American College of Obstetricians and Gynecologists, ACOG, reiterating it in 2006, it is said that in the absence of maternal contraindication, maternal request only is sufficient medical indication for pain relief during labor. Having said this, if you give it very early, what happens? What about maternal satisfaction? People who have experienced hunger, you see, real hunger, they only know the value of food. Every small bit of the food, they enjoy it if they know, if they have experienced real hunger. For others, many things matter. Taste, ambience, company, many things matter. The value of food is never understood. A lot of food is being wasted. Similarly, only those who experience strong labor pains appreciate the value of the absence of it, the analgesia. So, if you give it very early, and those who, if they have not experienced the pain at all, probably maternal satisfaction will be a little daisy. But otherwise, maternal request is good enough to give an epidural. The next one is bupivacaine causes motor block, increases operative deliveries, and is cardiotoxic, and should be replaced by either bupivacaine or bupivacaine. Yes, cardiotoxicity wise, it is true that bupivacaine has a higher propensity to produce cardiotoxicity. But what about the potency? Levobupivacaine is 20% less effective, and ropivacaine is 50% less effective. So when you try to use them, in fact, you're using larger quantities of bupivacaine and levobupivacaine. They also have cardiotoxicity, of course, in larger quantities. So it is again a question whether we are playing safe or not. When it comes to the question of other effects, motor block wise, ambulation, incidence of instrumental deliveries, incidence of cesarean sections, neonatal outcomes, in all these, probably to a certain extent, bupivacaine outweighs the other two. What about maternal satisfaction? Maternal satisfaction is greatest with bupivacaine. So bupivacaine is here to stay, at least in the foreseeable future. The next controversy is CSE is certainly superior to epidural. So let's compare the two, the combined spinal epidural and the epidural analgesia. Onset is faster with combined spinal epidural, true, but all other factors like mobilization, motor block, neonatal effects are all similar. Pruritus is more with combined spinal epidural, but it is because of the spinal narcotic that we use. Neuraxial infection rate is pretty high. Neuraxial infection rate is pretty high because we breach the dura. We still don't know what is the effect. So with all this, there is little basis for the routine use of CSE in preference to low-dose epidural techniques. But very early in labor, when the patient is still in less pain, only an intrathecal narcotic, if it suffices, give a spinal narcotic first and then make it a walking epidural. That probably helps you. Or late in labor, when the patient is in real agony and she is not even cooperating for placing an epidural, just give a simple spinal, make her comfortable, and then you can place an epidural catheter and then continue. So these are the two real indications for the CSE. So epidural infusions provide better analgesia than intermittent boluses. This is the next confusion. Now, if you compare, the drug spread in infusions is limited, but in the boluses, it spreads better. So if you see here, the left one is infusion. When you are infusing a local anesthetic mixture by the epidural catheter, the force of injection is very little because it is a slow injection. So the drug escapes through one of the holes into the epidural space, and because there is no pressure, it tries to stay there itself. So the spread is not great. Whereas boluses, when you are forcefully injecting, it spreads better. You have a larger segment which are covered. Motor block dose requirement is high in epidural infusions because the spread is less. You tend to increase the dosage. Motor block is high with the infusions because the drug gets concentrated in one area only. Over a period of time, that particular segment becomes motor blocked. So if you ask this question, infusions are better than boluses, the answer is no. Maybe they are almost equal, or boluses itself are slightly better. Epidural produces increased incidence of cesarean sections. This is a very important myth. See, after the 1997 report by Sharma et al., who said that there is no difference in the rate of deliveries, cesarean deliveries, between the analgesia produced by the two groups, and then with the Cochrane review, which said that there is no significant increase in the cesarean section rate overall and in terms of cesarean section for dystocia. So in both ways, it is not, it does not increase the cesarean section rates. If you see the incidence of instrumental deliveries, there is an increase in the use of instrumental vaginal deliveries with epidural, true, but it is a small price paid for greater advantages of the epidural blocks. Our own experience of 19 years from, this is a unpublished data, from September 2002 to August 2021, with the same set of obstetricians and the anesthesiologists, we had over 16,800 deliveries and an epidural take rate of a very high 80.64%. And the incidence of cesarean section in our setup, it was lower in the epidural group, about 18%, and in the non-epidural group, it was about 22%. So this is an unpublished data, our own study, our own. Whereas the incidence of instrumental deliveries during the same period, the instrumental deliveries in the epidural group was nearly 48%, and in the non-epidural group, it was about 24%, almost double. But we feel it did not have any kind of, fetal problems, so neonatal problems. So we felt that it is a small price to be paid. So if you ask this question, whether epidural produces increased incidence of cesarean deliveries, the answer is no. Epidural produces increased incidence of instrumental deliveries, answer is yes. The next question is, epidural needs to be discontinued in late stages of labor to enable the mother to push. This is again a myth, because to push, what she requires is the muscle tone of the abdominal muscles, which is very good. So we don't block the motor block, we don't produce motor block of the abdominal muscles at all. So she will be able to push. But the problem is that because the sensation from the perineum is taken off, that reflex bearing down is not there. So you have to voluntarily coax the mother to push. And when you do that, she will definitely be able to push. But if you stop for this reason, if you stop the epidural infusion in the second stage or don't give an epidural bolus, the intention of giving labor analgesia is lost, because the maximum pain is during the second stage. And if you don't give any kind of analgesia at that point in time, the very purpose of giving labor analgesia is lost. And the intention to reduce the instrumental delivery rates, if you stop the infusion, fail to demonstrate. So maternal satisfaction becomes extremely poor if you stop it. So in the second stage, if you stop it, it is very, very unethical. So don't stop it, continue to give. Epidural drugs have deleterious effects on the newborn. Suppose this is, of course, mainly the effects on the of the opioids. Opioids are given in the neuraxial, as I told you earlier, in very, very small quantities. So their systemic effects, systemic absorption, and then the neonatal effect is going to be very little. The action can be either direct or indirect, and indirect is because of the hypotension, increased use of oxytocin, prolonged second stage, instrumental deliveries. All of them do not cause, are not very significant, do not cause significant neonatal depression. Opioids, the quantity we use is less. So the answer to this question is no, because effect of fetal rate abnormality or meconium passage was no significant effect was found in the Cochrane review in the year 2000. So to the answer to this question, the answer is no. Mothers who have epidurals are unable to breastfeed. This is the next myth. Most studies in this are more than 30 to 35 years old. There was lack of randomization. Current evidence does not support this. And if you see the Cochrane review, which says that almost half the studies reviewed, because before 2000 it was, do not show adverse effects on breastfeeding. Then itself it was half the breast studies, but the studies which came up later on do not show that breastfeeding is affected by the epidurals. The next question is, the last question is, having an epidural, can I get postnatal backache? This is a real myth. There are two types of backache that can occur, acute and chronic. Acute, there is sufficient robust evidence to indicate that epidurals do not contribute to long-term backache in mothers after delivery. Very, very clear, crystal clear. Long-term backache has no relevance at all, no cause-effect relationship at all. But however, acute backache at the site of insertion of the needle, especially in a traumatic epidural insertion, up to anywhere between 7 to 14 days, is quite possible. So to answer this, acute backache postnatal is yes, is possible. Chronic backache is no. Myths and controversies are here to stay, but we need to get back and on our toes and see what the fact is. Thank you.